Almost 70% of women suffer from vaginal dryness, itching, painful sex, but almost no one talks about it. For far too long, we've spoken about menopause as if the only things women lose are their periods and their patience. But the truth is, the hormonal shifts of midlife reach far deeper, impacting our brains, our bones, hearts, and yes, our pelvic floor and urinary systems. Yet, when a woman shows up at her doctor's office complaining of vaginal dryness, burning, discomfort with intimacy, or recurring urinary tract infections, she's often met with a shrug, maybe a prescription for an antifungal, or worse, dismissal. This is not a minor nuisance. It's a condition with a name, Genitourinary Syndrome of Menopause, or GSM. And in April 2025, the American Urological Association, in collaboration with a few other organizations, finally gave this condition the attention it deserves in a newly released evidence-based guideline. I'm Dr. Manna, your friend and functional medicine doctor. Let's unpack what this guideline says and what it means for the millions of women silently suffering from this condition. So, what is GSM really? Genitourinary Syndrome of Menopause is not just vaginal dryness. It's a chronic, progressive condition that arises from the loss of estrogen and testosterone in the tissues of the vulva, vagina, bladder, and urethra. It affects nearly half of all postmenopausal women, though the real number is actually much higher since many women never bring it up and many clinicians don't ask. It can present as vaginal burning, irritation, dryness, or itching, pain or bleeding with intercourse, urinary urgency, frequency, incontinence, or recurring UTIs. The discomfort can be physical, sexual, and deeply emotional, impacting confidence, relationships, and the sense of ownership over one's body. The thing that I love the most about this new guideline is its absolute insistence that we believe women. That diagnosis be based on symptoms, not hormone levels or labs. A pelvic exam may help, but it isn't necessary. A woman knows when something has changed. She knows when her body no longer feels like hers. This means we no longer gatekeep treatment based on test results. If she says sex is painful, urination burns, or she feels dry and raw, we treat. So, in this guideline, there are 26 directives, 26 different guidelines going to making this one big giant announcement. And there are several different areas in which these guidelines have been announced. And the most important one, and the first one, is shared decision making. When it comes to Genitourinary Syndrome of Menopause, GSM, every decision should be made with you, not for you. That means you and your doctor discuss options together, review the evidence, and align care with your personal preferences, values, and health goals. Then, for screening and diagnosis. Now we're on to guideline number 2. If you are at risk for or are showing signs of GSM, your doctor needs to start with a focused and sensitive history that covers not just medical symptoms, but also sexual function and impact in your personal life. Number 3. A physical exam of the genitourinary system is essential when GSM symptoms are present. It gives us critical information that cannot be captured through conversation. Guideline number 4. Education is part of the therapeutic relationship. It is the doctor's job to help you understand that many of these symptoms stem from declining sex steroid hormones and what that means for your body. Number 5. The doctor must screen for coexisting genitourinary issues when evaluating GSM. If additional testing or a specialist referral is needed, then the doctor should do that. Number 6. If there are emotional, psychological, or sexual health concerns alongside GSM, it is appropriate to bring in a trained therapist to support you. Number 7. If the doctor suspects pelvic floor dysfunction, then this doctor must refer you to a specialist in pelvic floor physical therapy, which can be life-changing. Now, the guidelines move into hormonal interventions, so let's talk about those. Number 8, vaginal estrogen used at a low dose is one of the most effective ways to address GSM symptoms like dryness, irritation, and pain with intercourse. Number 9, Vaginal DHEA is another strong option. DHEA is a precursor of testosterone, and it's really helpful to support tissue health and function, and is especially helpful for vaginal dryness and painful sex. Number 10. Ospemifene is an oral medication that may be helpful for vulvovaginal dryness and pain with intercourse. While the evidence base for this non-hormonal option is smaller, it may be a good fit for some women. Number 11. If you are already on systemic estrogen, generally hormone replacement therapy, estrogen and progesterone, you can still benefit from local vaginal therapies like estrogen or DHEA. These options are not mutually exclusive. Number 12. If you have GSM and urinary symptoms like urgency or frequency, vaginal estrogen may help. In my personal opinion, vaginal DHEA is also, if not more, helpful. Number 30. If you have had to deal with recurrent UTIs, vaginal estrogen isn't just symptom relief, it can be protective and reduce future infections. Now let's move on to non-hormonal interventions. Number 14 in our list. Vaginal moisturizers and lubricants can make a huge difference for dryness and discomfort. They can be used with vaginal estrogen or DHEA. Number 15. There is no strong evidence that alternative supplements like vitamin E or vaginal soy preparations, etc., can help with GSM. As long as you're using estrogen and or DHEA, if you want to use these other preparations too, that's fine, as long as they work for you and you're not allergic to them. Number 16. Using cleansers and products that are irritating in the vulvovaginal area can make symptoms worse. Of course, you know that already. Then we move on to what we call energy-based interventions. Number 17 in the guidelines is, as of now, the science doesn't support the use of vaginal lasers or radiofrequency for GSM. Sometimes the vulvovaginal tissue can be friable or very delicate, and it can aggravate the condition. Number 18. However, if you're not a candidate for vaginal estrogen or DHEA, or for some reason if you prefer an alternative, laser may be considered with full information so that you can make the right decision for you. As long as you know that it is the laser is experimental and is approached through shared decision making, it's fine. So now let's move on to breast and endometrial cancer. Number 19 in our list of guidelines out of 26. There is no evidence that low-dose vaginal estrogen causes breast cancer. Number 20. If you are a breast cancer survivor, low-dose vaginal estrogen should still be considered. Number 21. Vaginal DHEA and ospemifene also show no evidence of increasing breast cancer risk. This is important information when you are weighing your options. Number 22. Vaginal estrogen is not associated with endometrial hyperplasia or endometrial cancer. Number 23. The same is true for vaginal DHEA and ospemifene. There is no evidence that shows any increased risks to the endometrium. Now let's talk about endometrial surveillance. Guidance number 24. We don't need to perform routine endometrial surveillance just because you're using vaginal DHEA or ospemifene. It's unnecessary unless risk factors are present, like unexplained vaginal bleeding or cramping, or some of these symptoms that need a biopsy or an ultrasound. Number 25. After initiating treatment, the doctor must follow up and reassess. Is the plan working? How do you feel? Does anything need to change? And number 26. Finally, know that managing GSM is often an ongoing process, not a one and done fix. Long-term support and periodic adjustments are part of quality care. You and your doctor must work together to ensure best long-term personalized care for you. So, if you've been dealing with burning, dryness, painful sex, recurrent UTIs, or just a vague sense that something's not right down there, please know you're not broken, you're not alone, and you're not imagining it. This is Genitourinary Syndrome of Menopause, and it is real, it is common, and it is treatable. You deserve care that's rooted in science, shaped by compassion, and aligned with your life. If this video helped you feel seen or sparked a question, I invite you to take the next step. Explore the resources on this channel and on my website. Share this with a friend who might be quietly suffering, and most importantly, don't settle for silence or dismissal. I'm Dr. Manna, your friend and functional medicine doctor, and I'm here to walk you through midlife and beyond, brain, body, bones, and all. Let's rewrite the menopause story together.